Good afternoon. I'm Meg Doherty from the WHO, or World Health Organization in Geneva, where I coordinate the treatment and care activities, which include developing of the global guidelines for low and middle income countries around both the treatment and prevention of HIV. And I'm really happy to be sitting here today with two wonderful women who are attending CROI meeting with me. Pamela Tshandu from the WITS Consortium and ACTG in South Africa, as well as Durueke Florita from Nigeria, who's with the new HIV vaccine and Microbicide Advocacy Society. Please.
Thank you, Meg. I'm Pamela Tshandu from South Africa, from an institute called VETS Health Consortium. I'm a CAP member there. I'm also affiliated with the AIDS Clinical Group, where I hold a co-chair position on CSS. I'm so thrilled to be attending CROI.
And I'm Durueke Florita from Nigeria. I work with an advocacy society called New HIV Vaccine, Microbicide Advocacy Society. So I'm really glad to be part of this team that will be looking at the community perspective on issues that affect Africa in terms of HIV prevention and treatment.
Great. So we think CROI has been really a fantastic meeting for issues related to treatment as prevention, women's issues, and I think we have a lot to discuss today for issues related to the developing world and low and middle income countries. So to start out, we thought we would talk about some of the really exciting studies that came out related to PrEP, or pre-exposure prophylaxis. And maybe I'll let Durueke start with her impressions of the positive, the good and the bad and the ugly related to PrEP and prevention.
I think I'm excited with the result we are getting from the CROI data that has been presented in terms of PrEP study. We have overwhelming evidence that the use of PrEP can actually prevent HIV transmission among men who have sex with men. And these are contending issues in Africa. Men who have sex with men are highly criminalized society. For instance, in my country, Nigeria, we have a lot of bills and clauses within the bill that really affect the ability of these people to get themselves protected. So for me, with the overwhelming evidence on the fact that the use of daily oral intake of PrEP provides protection for this community is really a relief for me as an advocate, talking about prevention issues for them. Also, we talked about the PrEP on demand, which also provided a more option on what the community can really use. Although PrEP has not been rolled out in my country, but I think the prospect is there. We have the evidence, to be able to advocate for possible inclusion of these tools within the prevention options.
Yes, I think so much data has been shown in CROI that PrEP indeed is working. Especially for the gay community. We've seen some results of the studies. But just to agree with Florita, and to just say, she mentioned mostly the positives. Just to touch on the negative, we're a bit disappointed, especially as the African community, with the FACT study, FACT 001. We expected that the researchers could have learned something from the VOICE study. We all know the results. The FACT study, which was for women, adolescent women from the age 19 to 24, which didn't seem to have so much efficacy, So we want to learn from that study and take we want to take the information back home and do better, in future.
Yeah, I think what's key that came out of these the 3 or 4 studies that were presented in that PrEP session were that PROUD and IPERGAY with MSM, either daily or on-demand oral tenofovir and FTC or Truvada works. But the question really is about facts, about using an intravaginal gel with tenofovir, that the levels of the drug didn't seem to be enough to work, or maybe that the women were not using it in enough, that the actual application around the sexual acts was not enough to protect against transmission. So that perhaps what we really have is an intervention that works really well in an oral form of the pill, either taking it on demand as needed around a sexual act or daily. And I thought what was very interesting was the presentation from Dr. Baton showing on Partners PrEP, that looked at PrEP as a bridge to full antiretroviral therapy in Uganda and Kenya. And what he showed is among serodiscordant couples that the negative partner of a positive partnership could take PrEP, daily Truvada, until the point in time if they did become positive, they would move to ARVs. But they saw very few transmission, practically none, and the only transmissions that they showed in those between those partners were when the person had no evidence that they were actually taking the drug in their blood. So we know that PrEP could work in a partnership where you have a positive partner and a negative partner to try to have that positive partner taking ARVs to keep their viral load suppressed. I mean, the goal here is just to reduce the viral load, right? So we reduce transmission. And the negative partner take PrEP in an attempt to keep the negative partner free of disease.
Exactly.
Do you think that would be something that the community would be interested? And are these partnerships and serodiscordant partnerships well enough defined that this would work in terms of actual rolling out this intervention?
I think it will, definitely, because this study actually reminded me of the HB10052,
Yeah.
which also had a 96% efficacy rate. So, I mean, when the results were presented, our community basically was very excited. We're very excited about the study. I think, looking back at my community, this can actually work, you know, especially for serodiscordant couples, where one is negative and the other one is positive.
And for me, I think I'm excited with this study. You know, looking back to fact and getting to learn that there's an alternative option for women, you know, gives me a lot of relief. The use of PrEP and also having it as a bridge in terms of ART is very promising. Yes, we may have talked about the challenge of somebody being negative and trying to be on treatment. You know, with proper education, we can really keep people on treatment. And again, when a negative partner also understand the fact that by the time my partner gets viral suppression, I'll be off drug, is also very promising. So for the community, we're expecting it in Nigeria. We are trying to do a PrEP demonstration study that will also have to engage the serodiscordant couples. So it's a whole lot of lessons and very promising for the community.
Yeah, so that's good. Let's shift gears and talk about prevention of transmission between the mother and the child, or what we call PMTCT. And there was an interesting presentation on the first day called the PROMISE trial, which was conducted in Kenya, Uganda, and South Africa primarily, looking at a 3-drug ARV regimen, what we call in the WHO option B or B+, versus an option A, which was a 2-drug regimen with some added ARVs or a tail around the delivery and the labor time. And it looks that the 3-drug regimen is more successful in reducing the transmission rates at very early time course of seroconversion to the infant. And that it was well tolerated by the mothers, but there is some concern that there may be some infant outcomes, but this regimen that was used in this trial included a very high dose of lopinavir/ritonavir with tenofovir and FTC or 3TC. So not the same regimen that we use, that we recommend from the WHO. So I'm wondering how you know, is the question about option B and B+ and ARVs for all pregnant women, is the question over, or are there other things that we need to know?
For me, I don't think the question is over, because if you really want to end the epidemic, we should be able to, you know, end pediatric infection. So if we have evidence that shows that this works, I think is the direction to go. However, we will also have to look at some community issues or structural issues that will have to affect the ability to keep these women on treatment over time. So we could have lots to follow up, and over time you could have drug resistance and all that. So what does this really mean? I think there is more need for community mobilization and engagement to really understand what they preferred, you understand, outside whatever the science is telling us.
Yes, and I'm also hoping with the PROMISE study you've just mentioned, Meg, that there'll be a follow-up, because there was some consent from some of the community members about the triple dose, you know, which was administered. Is this working? Is this not going to work? We still definitely need to follow up on the study and see if it really works. But as Florita is saying, the pediatric elimination of HIV is very important for us to reach 0 infections.
No, I think it's important, and I think you're absolutely right. The long-term follow-up of the women are very important, and to figure out at what point, during the breastfeeding period or even afterwards, that a woman who may be feeling very asymptomatic, feeling very well, no complications with her HIV, what would be her reasons for staying on ARVs for a long period of time? And so I agree. So interesting. But for us at WHO, it's helpful because it shows that our original recommendation makes some sense, so that's good. The next one I want to step into is now adolescence, a really challenging area. That we know that globally, some of the data coming out around adolescents are not that encouraging. Last year, they were noted to that HIV was one of their major causes of mortality. And we know that getting and keeping adolescents on treatment is a challenge.
It's a challenge.
Adolescents don't like taking medicines. Not all, but some. And we also know that the highest rates of incidence in places like South Africa and other places around the world can be in young women. So I think there's been a much greater focus on what can we do for adolescents, and are we doing the right thing? Is it the right treatment? Is it the right support? Is it the right everything? And how can we improve and reduce the mortality among adolescents related to HIV? So there was an interesting presentation called the Breather trial, where adolescents were given efavirenz and 2 nucleoside drugs around the world, including Thailand, Uganda, and Argentina. And they were allowed to take ARVs for 5 days and have the weekend off. And it seemed to be non-inferiority to continuous ARVs. What do you make of this? Is this acceptable?
For me, it's also another exciting evidence that we have in terms of options for young women. So if we have enough evidence that shows that it works, I think it's the direction to go, because the community will be able to have opportunity to be relieved of the drugs for a certain period of time, before they get on again. So I think it's promising. These are possible ways of delivery, and all we need to do is to measure and to make sure we have enough evidence that shows that we get more impact if we go this way, compared to what we currently have.
I would say the results of Breather are not really, really exciting, because not bad and also not just non-inferior, similar results to the other studies, which goes to show, because when I think of this study, also I think of the FACT study, which also involved teenagers and adolescents basically. So what is it that we're missing? What interventions need to take place? Because it's a study which basically gave them to a weekend off of not taking treatment, holiday. So we need to really, I would really urge the researchers to go back to the drawing board and also involve the community. I'm very passionate about education, community education, and whatever protocols they bring out, let's sit down, let's educate the community first, let them understand the pros and cons of these studies.
All right, great. I know one mentioned that they enrolled 8-year-olds to 24-year-olds, so that's pretty successful that we're seeing studies that enroll people in this sort of pre-teenage all the way up to young youth, so it's great. But yes, how these are taken up in the community and how it would work, and how to make sure that there's not mixed messages about adherence is important.
Exactly.
I thought we could talk a little bit about the Temprano study that came out of Côte d'Ivoire that showed immediate treatment at any CD4 count reduced the outcomes of severe bacterial infections and morbidity and other mortality by 44%. What do you make of this?
For me, when I pick the data from the Temporal study, it's more of providing evidence, from the previous community reaction, asking what's the benefit of treatment for prevention. If I might have a high CD4 count, why should I be subjected, to be on drug just because of my negative partner? So this study have been able to demonstrate some evidence of benefit for people living with HIV and AIDS, taking up early treatment, not necessarily to protect the negative partner as regard treatment as prevention, but they also have overwhelming evidence of improving their mobility and mortality, with the infection. So I think it provides evidence for further community education on the relevance of treatment as prevention and getting them to really uptake it.
This is quite a good study. Remember when our experiences as the community long time ago, I remember South Africa when people started to take drugs, the guidelines were saying that you should be below your CDF count should be around 250, and people were presenting with many opportunistic infections. But now, our guidelines say it should be above 500, and we're not seeing more of opportunistic infections. People are living longer, so this is quite a promising study which says that the sooner you take your treatment, the better.
Yeah, for those of us at WHO, it will certainly be an important study as we start to look again at global guidance, and it will help us to think about in what settings would immediate treatment make sense. And in this setting, it was primarily in Abidjan and Cote d'Ivoire, where there's lots of malaria, lots of bacterial infections. And what other exciting thing that came out of that study was they used INH, IPT prophylaxis, and also reduced the risk of acquiring tuberculosis by 33%. So I think that's exciting as well,
exactly.
Because IPT has been very difficult to have countries to uptake. I don't know if you have any thoughts. I know you attended a lot of the TB sessions, and maybe you could talk a little bit about what was exciting in TB and exciting in maybe the use of new TB drugs or the use of an isoniazid prophylaxis.
I'm quite excited about the new studies which are coming on MDR and XDR TB. We're seeing a lot of cases in South Africa of people presenting with it, and it's quite a burden. People are taking a lot of pills and injection, which is not nice, and people are taking strain out of it. Studies like 5319, which is going to look at TB and MDR TB treatment shortening, and we also have what's the name? I forgot the name. But I'm quite optimistic and excited about the new studies which are coming up. NC005. Yeah.
I think TB is the most killer disease for people living with HIV and AIDS. So most people living with HIV and AIDS have higher susceptibility to TB issues, and most of them die from TB. And for developing countries, we have a lot of factors that also drive possible acquisition of TB, looking at the housing and the environmental factors around it. So I think it's very, very promising, from the data we have, if people are on treatment quite early and we're able to reduce TB infection by 32%. I think it's overwhelming. It's something that we really need to support. But then we also need to think about how to facilitate uptake of TB services, because that continues to be an issue. How to probably talk about more community engagement and mobilization to promote the uptake of TB, the DOT services and all that.
Okay, great. And lastly, there were, I know, some studies that you attended that you're excited to talk about, or results regarding contraceptives and the risk or non thereof of acquiring HIV or interactions with our ARV medicines. Maybe you can give us some ideas about what you'd like to see.
Okay.
If you have the perfect study.
I think we have been, having a lot of discussions and conversations around the possibility of increasing women's susceptibility to HIV infection, from the intake of oral contraceptives, that is from DOPA and all that. So we have a lot of evidence on this, although most of the data comes from secondary analysis of other researches and investigations. So we need to design studies that will be able to answer the question, does contraceptive use actually increases women's susceptibility to HIV? We need to be able to take up studies that talk about that. But also looking at oral contraceptive use and HIV, we also have to look at maternal mortality, and be able to strike a balance. Why we are saying, we want to reduce HIV infection, what does it mean in terms of maternal mortality and all that?
Okay, well, I think we've covered a really wide range of important topics that have been talked about and presented here at CROI. Really exciting CROI for me. I feel like there's at least 5 or 6 important studies that are going to be important for our next set of guidelines. And as our guidelines really are talking to issues related to the developing world and low and middle income countries, we're really excited about what we've seen. So we hope to see some of these answers related to contraceptives, maybe more on topical PrEP or women-directed PrEP approaches in our next CROI next year. So thank you very much. Any parting words?
Yeah, thank you very much. I'm excited. Coming from developing world, I want to use this opportunity to advocate that we try as much as possible to bridge the gap between, the rollout of evidence in terms of HIV prevention and treatments in developing world. For instance, we have the PrEP already licensed in US and it's on there, and we're still discussing about PrEP. None has been licensed in Africa. So this is what we need to talk about, how to bridge this gap so that our science actually translates to practice.
This also has been a changing experience for me to be part of CROI, and I said to one of the researchers I spoke to earlier that I would like to urge all researchers to be community advocates too. Start there. Thank you very much.
Thank you, ladies.